Okay. So good morning, friends. And today we are going to talk about one of the very important attributes of a doctor. We just don't want simple healers. We want our doctors to be professionals. And that is where the whole issue lies. I recall what Sir William Osler had said long time ago. And these are really words of wisdom. If you read them, what he says, the practice of medicine is not a business and it can never be one. Our fellow creatures cannot be dealt with as a man deals in corn and coal. The human heart by which we live must control our professional relations. So, what it means is that it is not simply knowledge and skill that we are looking for, but something more than knowledge and skill, and what commonly goes by the nomenclature of art. I'm sure you would recall when we taught you the domains of learning. And that time we had the domain of mind, the domain of hands, and domain of hearts. Now, although medically we can say heart is not involved with thinking and other things, but going by the expression that is very commonly used. So we want people who have not only knowledge and skills, but who also have a heart, quote and unquote, to treat patients. Now, this presentation was actually meant for a face-to-face uh, interaction. So video, I'll show you little later, but we'll move further. Now, unprofessional behavior actually happens all around us. And here are just a few examples with their references. Doctors admit to unprofessional behavior at 3 Chicago hospitals. Unprofessional behavior, very common in US hospitals. Doctors behaving badly, they say it happens all the time. Lapses in professionalism of undergraduate medical students in a Saudi Arabian and a Scottish medical school. Now, these are the instances which I would say are only tip of the iceberg because somebody published them, somebody wrote about them. But if we look at the medical practice going on around us, I'm sure we can find many more such examples where doctors have indulged in unprofessional behavior. I have given my example earlier, and I'm sure some of you might have heard it also. But I just cannot forget that incident when we asked one of our residents to perform a lumbar puncture on a 1-year-old child. Now, obviously, when lumbar puncture was to be done, the child was crying, howling rather. And the resident took out a sticking tape, put it on the mouth of the child to quieten him, and went ahead to perform the lumbar puncture. We were later told by the nursing staff and other people who were standing there that this kind of thing has happened. Now, unfortunately, we don't record it. And even when we record it, we just record it. We don't take any action. Now, that is actually where unprofessional behavior grows. Take a simple example. Imagine you are traveling in a foreign land. You don't know the local people, you don't know the culture, you don't know the language, and you develop an acute chest pain. You are taken to the hospital. What will you look for in your doctor? And I would say, why even imagine a foreign land? Imagine an uneducated Punjabi going to Chennai and developing chest pain, or vice versa, a Malayali who doesn't know Hindi, who doesn't know Punjabi, coming from Kerala to Punjab and developing chest pain. These are difficult problems. We cannot leave them. That since you don't know our language, we don't know your language, so it's okay. Cannot do that. And so, if you look at the attributes that you would expect in the treating physician, I'll give you 5 to 10 seconds. Just think in your mind what attributes you would expect. And then I'll show my list. I'm sure you thought of things like this. He should be clinically competent. Important. The doctor should be able to explain your illness to you. Is it cardiac? Is it muscular? Is it just simple indigestion? He should put patient's interest above his own. Be responsible for quality of care. I don't want the doctor to say, since there are no equipment available, it's not my problem. I am not responsible for whatever happened to the patient. He should be truthful and honest. And he should be aware of the contemporary trends in treatment. Just reflect on this list again. And you would find that it actually represents most of the attributes that we want to develop in the Indian medical graduate. We want him to be clinically competent. We want him to be good communicator. We want him to be having altruism. We want him to be a lifelong learner. We want him to be a leader of the health team, and so on. So, what is professionalism? Professionalism is not simply following a vocation. See, a plumber also has a specialized training. He also works with equipment and instruments which we do not know how to use, but we don't call him a professional. An electrician has the same thing. We don't call him a professional. But an architect is called a professional. A dentist is called a professional. And if we see what is professionalism, there are many definitions, obviously. If you search the literature, hundreds, thousands of definitions of professionalism you can find. But the one given by Stern in 2006 is one of the most respected and most frequently cited definition of professionalism, which says that professionalism is demonstrated through foundations of clinical competence. Mark the words. Foundations of clinical competence, communication skills, ethical and legal understanding upon which are built the pillars of professionalism, namely excellence, humanism, accountability, and altruism. We'll come back to this if required. And based on this definition, Arnold and Stern, same year, they actually made a model of professionalism. So if you look at this model of professionalism, you can notice two important things. One is the base, and second is the pillar, on top of which rests professionalism. So communication, ethics form the base, whereas excellence, humanism, accountability, and altruism. Altruism means keeping the interest of the patient above your own interest. It may be a Diwali day, but if you have a casualty in the hospital, you would rather go there and leave your celebration. You won't say, I'll first celebrate Diwali, then I'll come and treat the patient. So that is altruism. So I hope you are able to conceptualize this model, which consists of the base and the pillars. And interestingly, The third and the most important base of professionalism actually is clinical competence. You cannot be a professional if you are not clinically competent. A quack, for example, can be very good at talking, can be very good at giving ethical practice. He may be very good at uh, prescribing you the best antibiotics and so on, but he lacks clinical competence. And that's why he can never be a professional. So the complete picture is like this. The base formed by clinical competence, communication, and ethics, whereas pillars formed by the four attributes that I told you just now. Let's look at some of the pillars as to what do they exactly mean. So when we say excellence, excellence does not mean only having the best knowledge and skills, but it also means a commitment to exceed ordinary standards. It's not that we can save a normal newborn. Excellence would mean you are working hard with your team to save even a 700 grams baby or even a 26 or 27 weeker baby. May be difficult, but yes, that is where excellence lies. So the commitment to exceed the ordinary standards, and that along with carries the concept of lifelong learning. You might have heard this. The half-life of medical knowledge is only 3 years or so. So that means by the end of 3 years, half of what you have learned is already outdated. And in other words, what it would mean is that by the time you come out of the medical school at the end of 5.5 years, most of what you have learned would be outdated. And we have seen all that. I remember when I was a student, the only antibiotics we had was penicillin and streptomycin. Anybody and everybody would inject penicillin. But by the time I came out of the medical school after doing my post graduation, nobody touched penicillin. Nobody knew about penicillin. So this rapid change is in fact one of the reasons for this concept of lifelong learning, which in a way is a dedication to continuous improvement for the quality of care. Accountability, simply stated, means taking responsibility for your actions. If I prescribed an antibiotic, I take responsibility. And not in the simple legal terms, but I take responsibility by justifying my action. I prescribed this antibiotic because the report said this is the one which will not create bacterial resistance. This is the one which will be very suitable for hospital acquired infection or whatever reasons I have to give. And very interestingly, this responsibility and accountability is not externally imposed. This is actually a self-regulating activity. When a doctor does not prescribe medicines to a patient who comes for getting an abortion done, it is not that he's scared of law or any other thing. It's a self-regulation. Your values, what you think about life, decides whether you indulge in those kind of activities or you don't indulge in those activities. Humanism, the respect, compassion, empathy, honor, integrity. And when we say respect, that means you are taking care of the other person with esteem, deference, and dignity, without bothering about the education, without bothering about the economic status, without bothering about the social position that a person holds, or caste and gender, and so many other. Empathy. And I'm sure you are aware of this, that empathy is very different from sympathy. When we say empathy, it is ability to understand other person's perspective without getting emotional. So when you go to the ward, and as pediatricians, we had to face this experience many times. Uh, when you go to the ward and you find a child has died and the mother is crying, you don't start crying with the mother. You feel the pain. You understand how she must be feeling. But you don't start behaving like that. That is empathy. The relatives, for example, would start crying with her. So that becomes sympathy. So empathetic response is very important for the physician. And in fact, if you look at the Hindi terminology, then that explains the two concepts very succinctly. When you say sympathy, it is suhanubhuti. And if you break it, it actually breaks into seh anubhuti. Seh, together. Anubhuti, feelings. Altruism demands that the best interest of the patient and not self-interest guides the physicians. I gave you that example of a festival. Compassion, feeling or emotion when a person is moved by suffering of another and by the desire to relieve. You could say it resembles empathy. Now comes ethics, and that is the base. We talked about the pillars till now. Now we come to the base. And sometimes there is kind of confusion between ethics and profession. People think it's one and the same thing, or sometimes they think they are totally different things. We'll look at this particular aspect. When we say medical ethics, then it is the ethical, moral, and values aspect that guides the medical profession. When you prescribe a medicine, when you advise a surgery, when you decide to conduct a cesarean rather than a normal delivery, that is where your values, your morals come. And morality is the social norm which distinguishes between right and the wrong. They are not written things. You could always justify a cesarean saving that I wanted to save the mother of the labor pain, or I wanted to, make sure that the baby doesn't have a complication. But would that be morally right? That is the question you have to ask. So ethics actually refers to professional moral conduct. Broadly speaking, ethics is what not to do. So it lists out what a doctor should not be doing. In a way, if you read the Hippocratic Oath again, it says a lot of things. Into whatever house I enter, I'll refrain from doing this, and I will not do this, and I will not charge money from my seniors. It's basically an ethical issue. Professionalism, on the other hand, tells you what to do. So keep that difference in mind. Professionalism is the set of guiding principles, what you should be doing. Ethics is a set of principles which tells you what you should not be doing. And both are important because everything cannot be fitted into either ethics or professions. And if we look at medical ethics, there are actually 4 pillars of medical ethics. Basically, what it means that all your actions should be beneficial to the patient. Don't take an action which will cause harm, the non-maleficence. There should be autonomy. Patient should be able to decide if he or she wants to undergo that line of treatment or, and the pillar of justice. So everybody is treated equally. Not that those who cannot afford are simply given some cheap substandard drugs, while those who can afford are being prescribed highly costly and expensive drugs. So the four pillars of medical ethics actually are benefit to the patient, not causing any harm to the patient, allowing the patient to make his or her own decisions, and being equal to everybody, irrespective of the economic status, the caste, the creed, the gender, and so many others. I already described this for you. So, ethics is the guideline that states do's and don'ts in specific contexts, whereas professionalism refers to the specific traits that are expected of professionals. Ethics are usually stated. When you go to get your degree registered, you are given a small booklet containing code of ethics. It's prescribed by somebody outside, whereas professionalism is cultivated by the individual person. You practice, you see, you work, and then you decide what you should be doing. So that's the major difference between ethics and professionalism. Next base of professionalism is communication. In fact, in this model, communication has been put at number two. So clinical competence, then communication. And in fact, if you look at it like this, then both are actually intricately related to each other. There can be no communication without competence. If you do not know what is the prognosis of this disease, how will you communicate? If you do not know what is the treatment of this disease or what is the interpretation of this lab report, how will you communicate? And vice versa. If you cannot communicate, then your clinical competence comes into question. A patient has a life-threatening disease, and you are simply not able to explain. You're not able to tell the patient what the problem is, what the treatment is, what the prognosis is. So communication and clinical competence are actually, to me, two sides of the same coin. Because communication doesn't mean, being goody-goody with the patient or telling jokes or making them laugh. Communication is about the disease, about the problem, about their life. And that cannot happen without competence. You have to be clinically competent to actually communicate effectively with the patient. And lastly, the lowest base of professionalism is clinical competence. Again, in one of the previous presentations, I had said that there are multiple definitions of clinical competence. But what has been given by Epstein and Hundert, 2002, is again the most commonly cited one. And I'm sure you all know, because of the competency-based medical education, that it is the habitual and judicious use of communication. Note the word communication. Knowledge. So communication has been placed before knowledge. Knowing and not being able to tell is like not knowing. So communication, knowledge, skills, clinical reasoning, emotions, values, and reflections in daily practice. That is the key word. So you might be doing, for example, saying Namaste ji to the patient in your OSCE station. But in real life, you are very different. So that doesn't count towards clinical competence. So to be competent, it should be in the daily practice for the benefit of the individual and community being served. If we look at various competency frameworks, And the earliest one which you can find in the literature is from Accreditation Council for Graduate Medical Education from US. So they gave 6 broad competencies for a doctor. And these 6 broad competencies included medical knowledge, communication, patient care, system-based practice, practice-based learning, and professional. So what I want to emphasize here is that professionalism is in fact one of the core competencies for being clinically competent. There have been many modifications. CanMeds, the Canadian system, for example. So they, and interestingly, if you look at the two models, they're almost same. Only thing is the names are different. So Canadians called it scholar, health advocate, collaborator, communicator, manager, professional. But what I want to register is that professionalism is there, unchanged. And then came the IMG framework. The names may have been changed slightly, but please remember, professionalism is part of the IMG competence. Now, of course, 2 more we have added, but still, professionalism is there because without being professional, you cannot be clinically competent. Now, if we look at what has happened over the years, we can notice some interesting trends. Initially, we started with the premise that professionalism is caught rather than taught. How can you teach somebody good behavior? You just behave good in front of a person, he will take your behavior. So that was the initial approach. But mind you, nobody said that for learning medicine. That you be with your teacher for 5 years and you will learn medicine. Nobody said that for surgery. So if it is not happening for medicine or surgery or pediatrics or ophthalmology, then probably it doesn't happen for professionals. So the second phase which came was to identify unprofessional behavior. The reason was that if a student shows unprofessional behavior, then this is likely to continue in later. I gave you that tape example. Quite likely that this person would still be indulging in this kind of unprofessional. But again, it's like this, that law and punishment have never been able to eradicate the crime. People know fully well that if they are caught killing someone, they would be hanged. But it doesn't prevent them from killing someone. So law is not a deterrent. And therefore, the next approach and the contemporary approach is to help the students to acquire a set of attitudes and values. So what is important is that from a very passive approach, we actually moved on to a highly proactive approach. So we don't tell now that they will learn professionalism on their own. Rather, we make efforts to help them acquire those attitudes and values. There are other reasons also. Why teach professionals? The legal and regulatory oversight. Every day we hear the cases of consumer protection being filed against doctors, even criminal cases being filed against doctors for supposedly unethical practices or unprofessional practices. There are patients have a lot of access to information. And many of you who are in or who were in practice like me would recall that when they come to consult you, They already have an internet printout in their pockets. You tell them take medicine A, and they'll say, "No, doctor, see here, this is what internet says." Or we talk to that doctor, and this is what he says. Or we talk to somebody in US, and that person says like this. So that access to knowledge, of course, it's always half knowledge. Most of the times, it is inadequate knowledge because they can't distinguish between what is given on the net is right or wrong. Anything written there for them is the right word. And more importantly, that students lack professionalism as much as they lack clinical competence. So you cannot take the approach that they have to be taught clinical medicine, but professionalism they'll learn on their own. That will probably do. Also, you need to keep in mind that professional status is not an inherent right. Simply because you have a doctor before your name does not mean that the society will give you the due respect. You have to earn that respect. And there are a lot of doctors who, in spite of having a degree and all those things, are viewed very poorly in the society. The maintenance of your professional status actually depends on public's belief that professionals are trustworthy. You know, we have come from a society where doctors were put on a pedestal equal to God. I remember one small joke. One fellow took his wife to one of the doctors, and the doctors examined the lady and said, "She's dead." And the wife said, "No, no, no, I'm alive." And the husband said, "Chup kar, तेरे को ज़्यादा पता है कि डॉक्टर को ज़्यादा पता है?" That this may be too much of imagination, but the fact remains is that what doctor says is sacrosanct. I remember as a small child when I had any sickness, illness, anything, and I won't listen to my parents, then they would take me to the doctor, our family doctor, and make the doctor tell the same thing to me: don't eat toffees. Now, that was the end of it because the doctor has said it. So, to remain trustworthy, you have to meet the obligations expected by the society. You know, same doctor, interestingly, to whom they took me, and I would sometimes see him walking on the road, himself eating toffees. Now, that is where a clash would come. Now, whether to trust or not to trust. So, these are the things which we need to keep in mind. And in fact, uh, if we look in the current scenario, most of the doctors who advocate lifestyle modification and losing weight and controlling blood pressure are themselves obese and hypertensive and diabetics and so on. So these are the issues where people, start questioning your trustworthiness and your profession. If you cannot keep yourself healthy, then they wonder if you really mean what you are trying to tell others. There are a lot of incentives and disincentives in the modern practice. If you are in a corporate hospital, doing a cesarean gets you more money. If you are in a tertiary care hospital, getting a CT scan, PET scan, MRI gets you more money. Now, whether it is needed by the patient or not is a different matter. But you have a choice whether you want to go for incentive offered by the system at the cost of the patient or not. Then, transparent working environment. Your companies would sponsor you for a conference. They would pay your airfare. They'll pay your family's airfare. They'll arrange a stay in a five-star hotel. Nothing comes free. I read many years ago when I was maybe third year or fourth year student. We had a medicine called cotrimoxazole. I'm sure most of you must have heard about it, Ceptran or Bactrim, which was commonly known. And the company manufacturing Ceptran made it a point that all books which had to mention cotrimoxazole actually mentioned Ceptran. So by the end of 5 years, the name Ceptran was so much ingrained in your psyche that for you it actually became a generic name rather than being a trade. Multiple players, specialization, you send a patient to me, I'll send patients to you. Patients themselves want, for headache, they want to go to a neurologist, and pain abdomen, they want to go to a gastroenterologist and so on. So all these things create trust deficit between the doctor and the patient, and which has an impact on professionalism. Now here come the real reasons. Students with history of unprofessional behavior are more likely to repeat it in later. And this actually comes from the second observation that physicians who were punished for unprofessional behavior or physicians who had a consumer case filed against them actually had a similar story happening during their student days. So when you have a student, for example, who forges your signatures onto the logbook, is very likely to repeat this behavior when he becomes a practicing doctor. And so it needs to be checked at that point of time. If it is not done, then probably it will become a part and parcel of his life. Whole lot of things. This actually comes at a time when we are having that admission issue. A very high profile examination, almost going to dogs, because somebody is willing to sell it, and more importantly, somebody is willing to buy. I wonder what these students' mindset would be, who enters a medical school after paying 50 lakhs, 60 lakhs for a question paper. What kind of professional attitude or behavior these students would have? But these are hard realities. Medical education is fast becoming a business. So at the end of 3 years of post-graduation, if you have ended up paying 2 crores, then you have to earn that 2 crores. That's as simple. You have not done a philanthropy. You have not given a donation. You have invested, and you have to recover that investment. Similarly, insurances, managed care. Many times people will come to you, वो mediclaim है, एक दिन का बना दो claim. So you show admission, and they claim money from insurance. Insurance company will not pay if there is admission less than 24 hours. So unnecessarily you admit a patient for 24 hours so that he or she can get insurance money. So, these kind of things distort professions. Even the reward systems in teaching institutions. Many medical colleges, especially in the private sector, would view your income more than your research or your publications. For them, that is more important. How many patients have you seen? How much money you have brought for the institution? So this distorts the total system. This is the typical journey of a medical student. You get admitted to a medical college as a nair, and then you have various teaching learning experiences, self-directed learning, you experience seeing patients, and then you see positive role models. Along with it, you also are developing maturity, and so you become a mature professional. This is what should be happening and must be happening in few cases. I'm not saying it doesn't happen. But unfortunately, the reverse phenomena is more common. They come full of idealism, but then they have bad experiences, then they get negative role models, then they see the negative politics in the institution and end up being a cynic rather than a mature professional. I remember during CMC days, we used to have an introductory program for the first year student. Each and every student would come on the stage. I have come to serve the humanity. And by the time they would reach internship or final prop, they would be USMLE, तो लिखना ही है. Something happens in between. Actually, we spoil the whole narrative. So from an idealistic person, we end up making it cynic. And that is because professionalism is no longer seen as something which has to be taught. We think they would acquire professionalism. They would get it from role models. Unfortunately, role modeling is a very, I don't know what to use, funny concept. Unlike a professor or a associate professor, role model is not a designation. Your university or your college doesn't say Dr. So-and-so is a role model in pediatrics or a role model in. The students pick up who is your role model. Now, it could be a good behavior or it could be bad behavior. Don't forget, somebody picked up Abul Kalam as role model. Somebody picked up Osama bin Laden as a role model. And you have no control over it. So leaving it, and interestingly, negative role models have more influence because they apparently have more power. I remember one of my senior professors, on the rounds, it was a terror. She would take the files, throw it on the face of the residents and scold the patients. The patient would start crying and then say, Dekha, मैंने कैसे समझाया? That was the kind of sense of power. And then I could see many residents actually transforming onto that side because that is where the power lies. So you cannot depend on role modeling alone. Role modeling has to be associated with a positive institutional culture. And therefore, what you need to do is to set the expectations. You have to tell them what you want them to. You should be assessing professionalism. If it is caught, you should be remediating unprofessional behaviors. You should be developing a system where inappropriate behaviors are prevented. And you have to implement a cultural change. That is one which is the most difficult, yet the most effective in cultivating professionals. So in the next one, we'll talk about assessing professionals. Because that is something which is lacking. In spite of 70 years of medical education in the country, we are still not at a stage where any institution can say that we are assessing professionals. Even the best of institutions. None of the All India Institute, for example, assesses professionals. None of the top ranked colleges assesses professionals. Everybody assesses knowledge and skills. But professionalism is actually much, much, much down the priorities. So we'll try to look at some of the issues about assessing professionalism and what role you as a teacher can play when it comes to assessment of professionals. So I would end here and I'll be happy to answer your questions and comments.
It's very common on professional behavior, day-to-day life. We are seeing it's very common in the media or in the physically also we are seeing. This is also very correct. The students who behave unprofessionally in their student life, they will continue the same thing in their professional life.
Yeah, what Dr. Pramod is saying is that unprofessional behavior is very common and is also not unusual to see students behaving unprofessionally. But again, we come to the same point that we don't really make effort to record these things, to take corrective action, and to make sure that such incidents are not reported. Even otherwise, for example, let's come back to that tape example. Now, if I had called the father and told him your son did like this and therefore he is being sent to sit home at 6 months and he should come back after 6 months, what response I would have got? Would he have said, yes, 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 he made a lot of mistake? No. It would be, "Nak साहब, बच्चा है, कोई गल नहीं, सीख जाएगा, छोड़ दो." And then lot of pressures and pulls and this and that. So that is because professionalism will come only when the society starts accepting only professional behavior and when society doesn't expect any unprofessional. But unfortunately, when the society itself contributes to reasons for unprofessionalism, the neat example is currently there. Somebody is willing to pay 50 lakhs. That's the height of it. So if somebody is willing to contribute to unprofessional acts, then it is unreasonable to expect that we would have total professionalism happening all around. These are difficult issues, but then we have to deal with it. You just cannot leave these things to happen on their own.
In time play a role in this, like suppose I have a busy OPD and I can't take care of the baby and in that procedure. So if in time play role in this, if time is limited and there are so many patients. So हर patient को वैसे हम treat करेंगे तो time ज़्यादा लगेगा.
What Shreya is asking is that often you have a pressure of time and then you are not able to give full care and full attention to the patient which he or she deserves. My answer would be put yourself in that situation. If you are a patient and your doctor says, I don't have time, would you be happy? No.
So
It's the only thing is,
this only happens that when we visit the doctor, we hardly get 5 minutes or 10 minutes. Complete history भी अगर हम बताएं तो दिन हम
yeah, communication is another thing which probably we need to talk about sometime. Most of the times, and this is research based, doctors actually start writing their prescriptions
without listening to the
within 10 to 15 seconds of patient speaking. So before even he comes to the actual complaint which brought him to the doctor, they start writing a prescription. So communication is another issue which actually we should be talking about. But then I don't think lack of time would be a excuse for not giving enough attention to the patient. So you could do some kind of a triage. You have 30 patients sitting and you have only 1 hour. Identify people who are sick. Identify people who require more care. Devote time to them. For others, you can call your other colleagues or you can give them another opportunity or another appointment. That's what we have to do. In fact, the best way to learn about this is to go to a government office for some work. And then you would realize what it means to be waiting for somebody. Only yesterday, I went to LIC office to have something sorted with my policies. For 2 months, they were lying in their office. They never sent it back to me. हाँ भेज देंगे वो आज वो छुट्टी पे है. I said, but somebody has to be working in वो hospital में admit है. Still, somebody has to be working in वो चाबी उसके पास है. आप कल आ जाना. So that's the problem which you face only when you are on the other side of the table. Most of us are not experienced life from the other side of the table. You see there, and then you'll realize that probably it's very harsh to really tolerate these kind of things. But then it also teaches you a lot of things that when you tell a patient, "Aaj nahi kal aana, aaj report nahi ready, kal aana," then how they must be feeling. Only thing is they cannot say it to you, but surely they feel about it. Anything from the participants? Okay, if there's nothing, then thank you very much. And maybe next week or maybe after that, we will be talking about assessment of professionalism and some of the common things which we can do to prevent unprofessional behavior. Thank you very much.